We'll be discussing gene expression profiling in breast cancers in this short video. Gene expression profiling is not commonly done in routine clinical practice. Indian patients, for two reasons. One, patients who present to us with such an early stage breast cancer is less compared to the West, where there is screen detected breast cancer. And number two, the question of affordability. So what are these gene expression profiles? What do these tests mean? Oncotype Dx, Mammaprint, and so many new tests have come up. What do they actually mean, and when do we use them in clinical practice? These are just clips from NCCN guidelines. So as we can see, Oncotype Dx has specific indications which are approved by NCCN as Category 1. We'll be discussing about these in detail. So all of us are made up of different genetic material that determines everything from our hair color to the eye color to the way we to our height, our weight, the way we talk, everything. So we are made up of so many genes. So similarly, tumors are also made up of so many different genes, and the genetic makeup of a particular tumor will determine how aggressive the tumor is going to behave. Is it going to recur soon after treatment, or is it going to be an indolent tumor for a long time? So, this genetic makeup of a particular tumor in a particular patient is what we are trying to analyze by these gene expression profiling. It is as simple as that. So, a prognostic factor, we call something as a prognostic factor when the presence or absence of the factor would determine a good prognosis or a bad prognosis. For example, lymphovascular invasion, if present in a particular tumor, is a bad prognostic factor. It holds true for almost all cancers. We call a factor as a predictive factor when the presence or absence of that factor will indicate whether that particular tumor will respond to a particular treatment. So, for example, the presence of hormone receptors in breast cancer is predictive of response to endocrine therapy, whereas the absence of hormone receptors is predictive of absence of response to endocrine therapy. So, this oncotype DX is prognostic in itself when hormone receptor positive breast cancers are treated with endocrine therapy alone, and it is also predictive for a benefit of adding chemotherapy to endocrine. So basically what Oncotype DX tries to answer is a simple question: will a patient benefit from adding chemotherapy over and above endocrine therapy? So it studies the expression of 16 genes plus 5 reference genes. It's done with an RT-PCR method. The ultimate aim of this score is to arrive at a recurrence score. So there is this trial called the Taylor X, in which 10,000 patients roughly with T1 and T2, that is less than 2 centimeter, node negative, hormone receptor positive, HER2 negative breast cancers underwent this Oncotype DX to arrive at a recurrence score. Any recurrent score more than 25 would automatically require chemo by trial design, because a high recurrent score basically means that a very poor biology tumor. So we would not want to include such patients to a trial, and all patients with a recurrent score more than 25 received chemo. Any patient with a recurrent score less than 10, a low risk of recurrence, a very good biology tumor. So only endocrine therapy was given as per trial design. So now if the recurrence score was between 10 and 25, that was a study population in this Taylor X. So in this study population, patients were divided into two: people who received only endocrine therapy and people who received endocrine therapy along with chemotherapy. So this is the question that we are trying to answer here, and it was found that in the study population, that is in a T1 or a T2 node negative, hormone receptor positive and a HER2 negative breast cancer patient, if an oncotype DX is performed and if the recurrence score is somewhere between 10 and 25, there is no benefit of adding chemotherapy over and above endocrine therapy, and only endocrine therapy will suffice. So basically, the patient is avoiding the toxicity of chemotherapy, systemic chemotherapy. So that was the conclusion of this Taylor X. So the conclusion was again summarized: more than 50 years of age, postmenopausal women, T1 or a T2 node negative, hormone receptor positive, HER2 negative breast cancer. If the recurrence score is more than or above 26, definitely add chemo. And if the recurrence score is less than 25, there is no benefit for adding chemo over and above endocrine therapy, because this was a study population. So women less than 50 years of age or premenopausal women. So what do we do? So as a very basic concept, lower the age, higher is the risk of recurrence in breast cancer, because for a longer duration the patient is going to be exposed to post treatment surveillance period. So a premenopausal woman by inherent nature carries a higher risk of recurrence than a postmenopausal woman with a similar hormone receptor profile, with a similar IHC marker profile. So, in a younger woman, we tend to lower the cutoff of our recurrence score for considering chemotherapy. For example, in a postmenopausal woman, we considered chemotherapy when the recurrence score was more than 25. In a premenopausal, less than 50 years old woman, we consider adding chemotherapy over and above endocrine therapy when the recurrence score is even 21. In a recurrence score between 16 to 20, we again use clinical risk stratification. We look at other parameters like LVI, PNI, and all that, and counsel the patient and make a joint decision with the patient about adding chemotherapy over and above endocrine therapy. So this is about node negative population. So there can be patients with a less lymph nodal burden, up to three positive lymph nodes. Can we still use Oncotype DX to decide, can a lymph node positive breast cancer patient avoid chemotherapy? That is the question that we are trying to answer here. So that was evaluated in the RX Ponder trial, where about 5,000 patients who were both premenopausal and postmenopausal, who had up to three positive lymph nodes, underwent Oncotype DX. And when the recurrence score was less than 25, the there was no difference between endocrine therapy alone or endocrine plus chemotherapy alone in terms of disease-free survival. It's 5-year disease-free survival. Of note, 10% of the study population had a high grade disease. 10% of the study population had three positive lymph nodes, not just one or two, three positive lymph nodes. So, if we look at an isolated patient with a high grade IDC, which is IDC grade 3, with three positive lymph nodes, we tend to sway towards chemotherapy, obviously. That's natural, but still, we have scientific evidence to show from RX Ponder, even in such patients, if they are T1 and T2 node up to three positive lymph nodes, as long as they are hormone receptor positive and HER2 negative, they are going to respond to endocrine therapy well. And we can counsel the patient, we can discuss the patient with the patient about the feasibility of using Oncotype DX even in this setting if they are keen on avoiding chemotherapy. In the node positive setting, so the final conclusion is the postmenopausal women, there are two options. Option one is use Oncotype DX and risk stratify. If the Oncotype DX recurrence score is less than 25, we can avoid chemo, and more than 25, we can give chemo. Option two is give chemo to everyone. While discussing with the patient about Oncotype DX, we also need to discuss with the patient about this EBCTG meta-analysis, where addition of chemo was shown to be beneficial in patients with positive lymph nodes. So in this case, if we decide to give chemo to everyone, basically in our scenario where we do not use Oncotype DX at all, we decide to give chemo for all node positive patients. When we do that, we are not harming anyone. We may be overtreating some patients. We may be exposing them to the additional toxic effects of systemic chemotherapy, but we are not harming anyone in this approach. So these are the two options which can be considered while discussing with the patient about adjuvant therapy. In premenopausal women, again, the opinion is divided. Some use Oncotype DX based on the RX Ponder trial. Some use chemotherapy for everyone with a node positive disease. What are the other genomic tests other than Oncotype DX? This is the next commonly talked about genomic expression profile, the Amsterdam. So in Oncotype DX, we evaluated 15 genes plus 5 reference genes. Here we are evaluating about 70 genes. It's also commercially called as a Mammaprint. It can be done on an unfixed, fresh, frozen tissue, or it can be routinely done on a formalin fixed paraffin block. So this is also one of the uh, gene expression profiles which can be used to decide if a node positive patient can avoid chemo. So in this about 6,500 patients, 80% were node negative, but 20% had up to 3 positive lymph nodes. So while discussing the adjuvant therapy, we look at the histopathology report. We look at so many factors like tumor size, number of lymph nodes, LVI, PNI, grade of the tumor, the SBR grading, and all that. So, so these are called as the clinical risk factors for considering adjuvant chemotherapy. Now, by virtue of its genomic profile or its genetic makeup, if the tumor was to behave an indolent tumor, was if by genetic makeup the tumor is a low genomic risk tumor, so there comes a question. The patient clinically has high risk factors which would warrant adjuvant chemo, but genetic makeup is suggestive of an indolent tumor. So, what tool do we use to decide whether to give chemotherapy or not? So this was Mammaprint. This was evaluated in the MIND Act trial, where about 1,350 patients who were hormone receptor positive and HER2 negative. Of course, all these gene expression profiling to avoid chemo is done only in hormone receptor positive patients, not in hormone receptor negative, not in HER2 negative or triple negative patients. So 1,350 hormone receptor positive and HER2 negative patients were evaluated with the mama print. So basically, their tumors' genetic makeup was studied. 70 genes were studied in this mama print assay. So when they were stratified as per their age and for their lymph node status, in patients more than 50 years of age who generally carry a lower risk of recurrence than patients who are younger and premenopausal or less than 50 years of age. So there was no difference at all in the 8-year distant metastasis free survival between patients who received chemotherapy and who received endocrine therapy alone. So these patients received endocrine therapy alone had a 90% 8-year distant metastasis free survival. These patients received chemotherapy over and above endocrine therapy had a 90.2% 8-year distant metastasis free survival. So it's a very simple thing. So these patients were had some high risk clinical high risk features which would indicate chemotherapy, but their genetic makeup was so good that they had low genomic risk and they avoided chemotherapy to achieve a very similar distant metastasis free survival to patients who received chemotherapy. So basically, they have also avoided the systemic side effects of toxic chemotherapy. When patients were stratified as per node status, also, even in patients who had up to 1 to 2 positive lymph nodes, there was no significant difference in the 8-year distant metastasis free survival. So, this is the conclusion of the MINDAC trial, where Mammaprint is another assay which can be used to decide to avoid chemotherapy in hormone receptor positive HER2 negative patients who can even be node positive but up to 3 positive lymph nodes only. So basically, in summary, Oncotype DX and Mammaprint can be used in hormone receptor positive HER2 negative patients to decide about avoiding chemotherapy. For that, they have to be T1 or T2. They if they are node negative, it's well and good. Even if they are node positive, up to 3 positive lymph nodes, both Oncotype DX is approved for this indication based on RX Ponder, and Mammaprint is approved for this indication based on MIND Act. What are the other genomic expression profiling other than these two common things? PAM50 risk of recurrence score, again very similar to the one previous two, evaluates 50 genes and generates a risk of recurrence. And PAM50 is the test which originally classified breast cancer into the uh, luminal subtypes, HER2 enriched and TNBC subtypes. So we know that these subtypes are broadly remembered as luminal subtypes being remembered as hormone receptor positive, HER2 negative, and HER2 enriched being remembered as HER2 positive, may or may not be hormone receptor positive, and TNBC as all three negative, HER2 and hormone receptors are negative, and with a high Ki67, which is a proliferative index. So, what IHC4 did was, instead of a genomic analysis of 50 genes to divide into four subtypes, this is a simple IHC immunohistochemistry based test of just four parameters: estrogen receptor, progesterone receptor, HER2, and Ki67. But it cannot be just a casual IHC which is done in any laboratory. It has to be done with strict quality control for staging and treating, and the results are placed on an equation to arrive a score of IHC4. And this can also help us in deciding if patients with hormone receptor positive, HER2 negative tumor patients can avoid chemotherapy if they are node negative. So these are two other genomic expression profiles which